12:05. So I think we'll kick off from there. So good morning, good afternoon, and welcome to you from wherever you're coming in and whatever your role. Welcome to the Cardiac Virtual Wards Tried and Tested webinar. Bit of a mouthful, but it's going to be hopefully a very exciting, stimulating kind of hour ahead for you, or 55 minutes ahead for you. I'm Nick Nijelomsky. I'm the COO of Ortus and your host for today. And I'm not going to give you any kind of sales pitch, but for those of you who don't know who Ortus are, just 1 minute on it. We're a leading specialist provider of cardiac and cardiology-related virtual wards and remote monitoring. We were founded in 2017 by a cardiologist, and our platform includes clinical and patient portals originally developed and built not only by, but also for cardiologists and their patients. Since then, we have actually added a lot more functionality to the platform, but so it could be now it can be considered to be condition agnostic. But to borrow an old expression and an old saying, you can take the platform out of cardiology, but you certainly can't take cardiology out of our platform. So, on to today. We promised you case studies and insights on virtual wards. That was to include journeys, best practice, and the results. And that's precisely what our speakers today will be delivering for you. We've got three key speakers. You're going to hear from them, and you'll hear from them in this order. We'll be starting off with Debashish, Dr. Debashish Das, a consultant cardiologist, transformation lead, and actually the founder of us here at Ortus. And his case study will cover the London Cardiac Networks. It's a case study covering the bringing together of cardiac networks across the capital with a reach covering the whole of London. He'll be followed by Dr. Dan Jones, a consultant cardiologist and an award-winning researcher, he probably hates it when I say that, on his use of virtual wards with the Atlas pathway, specifically for NSTEMI patients. And then the final presentation will be provided by Martin Yates, a consultant cardiothoracic surgeon and the remote monitoring clinical lead, about his experiences of virtual wards, using virtual wards to convert non-elective patients to elective patients. Following those presentations, which will be sort of 15 minutes, we'll have a final session in the form of a questions and answers panel. Now, we know you're busy, and so we will focus on being able to deliver this for you within the hour we promised. But before we start, what I'd ask you to do is please enter your questions and any questions you have during the presentations into the chat. And one of my colleagues will help compile those questions so we can bring them forward into the Q&A panel. Also, the session is being recorded, and should you not wish to be on the recording, you can drop off if you don't mind. Then we continue, but everyone will receive a replay after the event, and that replay will include details of contact details, so that if you wish to follow up with speakers or obviously ourselves, we'll be able to go. So. Right, I think that's about it at this stage. So that's far too much from me, and I will hand over to Dr. Debashish Das. And I will disappear. Over to you, Debs. Thank you.
Great. Thank you, everyone. Hopefully everyone can see my screen and can hear me. Thanks. My name is Debashish. As I mentioned, I'm a consultant cardiologist. I founded Ortus for the exact reason in 2017 as a eager registrar at the time. My boss and clinical leader happened to be the CEO, which was helpful. And when I gave him the idea, he kind of said to me, "Debs, I don't know what you're talking about, but give it a go." And it has led to 7 years down the line, and we are here today. I wanted to show what happened basically from post-COVID and what's really led to the expansion, as most people have heard since then, that the more of the use case of kind of remote monitoring in cardiac virtual wards. But the challenge that was set across London was first in line from kind of cardiac surgery as the primary driver. We have on average about 1,800 to 2,000 patients waiting at any one point in time in London. We were seeing post-COVID increased number of our P2 patients and longer waits. And we were worried that we were going to go back to the older kind of days of patients coming to harm due to kind of long waits. NHSX was involved in this project and put £750,000 worth of NHS funding to cardiac networks to see whether remote monitoring could potentially help risk mitigate these patients. So this is what we were seeing across London. These are some of the reports that we do on a monthly basis, keeping a track of our wait across the various surgical sites. And again, what we were seeing was reduction of our business as usual activity, increase of our wait. We also track on each site the clearance times of the waiting list, so how long it will take each site to get through their P2s, P3s on current trajectory. And again, we were seeing increasing clearance times, all giving the rationale behind how could we risk mitigate patients, how can we bring potential patients forward who are deteriorating. So the idea was to remotely monitor those patients who are waiting for deterioration. But actually, on the offset, we wanted to really try and do an end-to-end pathway, focusing on the pre-hospital. But can we then, once we have these patients, be able to either bring them forward earlier if they're deteriorating, but also enable early discharge? So we very much up front, 2-3 years ago, had the thought process of having really stepped down virtual wards for these patients as well. So as you can imagine, these are all the centres that got together, and it's remarkable that we all got together and agreed, which is one thing, knowing the centres, but we also agreed that we wanted one solution and one pathway, a unified SOP for our cardiac surgical patients across the sector, but bearing in mind, knowing that once we do have a unified remote monitoring solution, cardiac surgery was always just the first pathway that we had in mind, and hoping that bringing something like this would spur on other innovation. So in December, there was a procurement process. Each site had their own kind of remote monitoring solution, but there was a want and a need to unify it. So rather than a fight between each centre, they went through a procurement process, and Ortus was chosen. And Ortus really is it's a remote monitoring, a virtual solution, but it also tries to digitize much of the journey as well through pre-assessment forms, proms, digital content. There was a high degree of technical specification that was wanted in this path, is that not only to help remote monitoring, because we know that remote monitoring of virtuals is more work for our staff, but could we release some efficiencies through digitization of other parts of the pathway that would then offset the increased work that remote monitoring would do. And that's what Ortus tries to do. It also allows easy, quick configuration for different virtual wards or different remote monitoring lists very quickly, such that you can see your quantitative data, be it observations, but a lot of our virtual boards are more reliant on qualitative data, symptoms reporting. And in fact, different symptoms are important for different virtual wards that we have. So each list we can create algorithmic based questionnaires specific to your pathway that would highlight deterioration, and deterioration specific to the symptoms of your choice. So our heart failure virtual wards will have a different algorithm questionnaire to our cardiac surgery or to our NSTEMI. And within that virtual remote monitoring, you have all the tools to be able to try and manage these patients as asynchronously as possible. Some of our centres were already doing remote monitoring, but through telephone. And we know that takes time. What we didn't want to create was more 111s out there across the centre. So how could we utilise the tools to gather as much information, clinically relevant information as possible from patients, but then manage these patients asynchronously through the messaging functions? So we unified an SOP across all cardiac surgical centres, asking for patients to submit our cardiac surgery questionnaire with a specific algorithm set for deterioration. Stable patients would be highlighted as grey, and those deteriorating based on the algorithm, amber or red. And they will be remotely monitored by our AMP staff on a weekly basis. Any red flags would be reviewed by the AMP and then escalated if they felt appropriate to the responsible cardiac surgeon, and then expedited to surgery. And as I mentioned, we took the opportunity in these pathways to digitize other components of it through pre-assessment forms, content for the patient. So at BART, the cardiac pre-assessment pack that was often given to the patients are now sent through the portal digitally. So what did we do? As you can imagine, this is a large-scale project delivered in what I would say quite a rapid time. So we went live through each site within kind of 6 to 8 months, and we have, this is slightly old data now, but it's over 8,000 patients have been put through the pathway. And in London, we have had over 432 patients escalated and brought forward for surgery in 2 years. The pathway was evaluated independently by UCLP, and these are some of the key findings that came out. So the primary objective of the pathway was achieved. We were able to, through remote monitoring, identify patients at risk, deteriorating, and bring them forward for surgery at scale. We were able to analyse that actually those who engaged with the pathway and were remotely monitored were less likely to become an urgent unelective case, i.e. landing up in accident and emergency. And those who were brought forward through remote monitoring fared better than those unelective cases brought in by the front door. And where there was remote monitoring already done through kind of telephone, through the asynchronous method, we were cost effective, £345 per patient via this pathway. Now, of course, I've just highlighted all the positives, but there were negatives, and largely a lot of the negatives were through implementation and communication with patients that we have and we are subsequently continuing to address. Our method for rollout was very much, this was an urgent thing to be done, so we've taken an agile process to delivery, learning quickly where we're making mistakes and adopting them. And a lot of the key to success for this is really good patient communication, letting know the patients what the pathway is about. And that's what our focus is on now. This is business as usual, but really trying to take where we have 80% patient activation and engagement, we're trying to bring that further as much as possible, close to 100%, with a motto, leave no patient behind. So what has that then done? And it has inspired other pathways across the sector in London, of which you'll hear two 2 more today. It's also blurred that gap between cardiac surgery and cardiology. We treat these patients as one and the same now. They're cardiac patients. We've had various new pathways, from low-risk NSTEMI pathways, monitoring our aortic dissection. We have atrial fibrillation virtual wards through PPG monitoring. We have long-term condition now remote monitoring across different sectors through cardiomyopathy or inherited cardiomyopathies and so forth. And we've just set up in BART our grown-up adult congenital cardiac disease remote monitoring and virtual wards. So that's a whistle-stop tour of what we've done so far. If there are any questions, I'm happy to have them afterwards.
Thanks, Debs. Excellent. Thank you very much. Right, so please, I put a note in the chat. Please fire your questions in so that we can get those pulled together later on. And I see that Dan has already joined us. So Dan, it's over to you. Hi, we're just going to see if we can patch Dan through differently. Hear you. Can I suggest that maybe we cut over to Martin, and Dan, we try and sort that out on the side? So Martin, let me just bring you in now. You want to share? So
great. Good afternoon, everyone. Is my audio working okay? Fantastic. Great. So thank you for joining us this afternoon. We'll do this in slightly reverse order now, because what we've done in cardiac surgery led on from Dan's work in cardiology. So my name's Martin Yates. I'm a consultant cardiac surgeon at St Bartholomew's Hospital, and I lead remote monitoring for our surgical patients. And what I'd like to describe to you is how we have taken non-elective patients and converted them to elective patients through remote monitoring. As Debs has described previously, the wait for cardiac surgery across London and across the United Kingdom has significantly increased since the pandemic. The time that the patients waiting for cardiac surgery has increased, and the knock-on effect, therefore, has been that an increasing number of patients are waiting in hospital for non-elective surgery due to the long elective waiting times. And in London, that's somewhere between 7 and 28 days for non-elective surgery, although I know that across the country it can be significantly longer. So the aim of this project was to monitor patients at home whilst waiting for urgent cardiac surgery safely. The pathway we used for this is that all patients were referred for urgent coronary artery bypass grafting by a consultant cardiologist and were reviewed by a consultant cardiac surgeon. And that consultant decision-making was very important for this pathway to work. At the point of referral, all of the patients had their basic investigations completed so that they could be reviewed, and we knew that they were normal. And then they were booked for surgery within 14 days as the first priority case on a list on that day. Again, at this time, we made a medication plan to ensure patients were on the safe antiplatelets for their discharge, but also to allow surgery to proceed. And the medications that would prevent surgery proceeding were all stopped at that time. In terms of the monitoring for these patients, we met them whilst they were in hospital, and they all agreed to go home with remote monitoring. They received one phone call on day one to ensure that they were all set up. But following that, they would then fill in a daily symptom questionnaire on the Ortus app until the day of their surgery. And they were admitted the day before surgery, having their surgery the following morning. Any patient who described any chest pain whilst at home were admitted the same day electively onto our surgical ward for assessment, and then had their elective surgery performed subsequently. We started off doing this in December 2022, really just as a proof of concept. And this was myself doing 1 or 2 cases per month to prove that it was safe for the patients and that it worked for the department. And if we can go to the next slide, you'll see that over the course of the time since then, we gradually increased the number of patients that we were operating on, with June of this year being the most, where we did 10 patients. And remember, these are all patients who 2 years ago would have stayed in hospital for urgent surgery for a significant length of time, have now been able to go home and have the surgery done on an elective basis. So in total, we've now converted 96 patients from non-elective to elective coronary revascularization. And I just want to take a little bit of time to run through this pathway of what happened to those individual patients. So of the 96 patients that we've recruited onto the pathway, of course, the initial decision was for 96 of them to have surgery. And if we follow that down, we can see that 91 went on to have successful remote monitoring with no escalations within their time to the operation. We did have 4 patients out of the 96 who flagged on the remote monitoring. 2 of those we admitted electively, and they still went on to have elective surgery. 2 of them we managed to escalate their medical therapy remotely whilst they were at home, and they came in on their planned day. We've had 1 patient who was an unplanned admission who had a primary PCI to right coronary artery and went home well, and subsequently came back for elective revascularization of their left-sided bystander disease. And if we just go down to the left-hand side box, 2 interesting things that we saw during this pathway. During our initial experience, there were 3 patients who'd gone home in remote monitoring who then declined their initial admission. 1 of those subsequently came back to have surgery, and 2 chose not to be revascularized. And one of the unintended benefits we found, there was 2 patients who had their coronary angiogram late on a Friday, and we were undecided the best pathway, whether they should have surgery or PCI. We monitored them over the weekend. They came back the following week and were seen by both myself and Dan, and opted to perform elective PCI for both of those patients who went home the same day. Next slide. We show this slide of the demographics of the patients for a couple of reasons. They tended to be younger patients. They tended to be male, but that was not in any way by selection. But particularly, we wanted to show that 86% of these patients were troponin positive presentations. So these are genuine patients that previously would have stayed in hospital for urgent surgery. The 20% who had stable angina were deemed to be urgent based on the severity of the coronary artery disease, despite the fact their symptoms were stable, and therefore underwent expedited surgery. Our protocol suggested the patients could spend 14 days on the pathway, but actually our mean length of time was 8 days at home, with the patients coming in the day before, and the mean post-operative length of stay of 6 days matches our elective patients, with our non-elective coronary revascularization post-operative length of stay being between 7 and 8 days. It's obviously important to know how the patients feel about this. Next slide. We started this process at Barts and with one of our referring centres at Whipps Cross, but very quickly over the last year we've now expanded it, and you'll see from the next slide, to encompass most of the hospitals across North East London, so that patients all across the region are able to benefit from this. Next slide. And what we can see is that we have to check the patients are comfortable with this process. You can see here from the top that the majority of patients would recommend this pathway to a friend. The vast majority had an overall very good or excellent experience, and all but 1 patient felt safe going home prior to their operation. The benefits to this are not just around the patient. So the patients seem to like it, particularly the idea they're allowed to go home and prepare for their surgery. They know when their operation is going to be and the surgeon who's going to perform it, and they know the outcome of all their preoperative investigations before they go home. In terms of the cardiologists, it will buy you as many bed nights per patient as your current inpatient stay. And of course, these beds don't remain empty. In fact, this allows cardiology elective workload to continue through those beds. For me as a surgeon, I get to meet my patient in advance. I know who they are, when I'm going to operate on them, and I've seen all their preoperative investigations. And aside from all of that, there are huge benefits to the system. We've reduced the number of cancellations. In the last 6 months, we've had no cancellations related to the patients in the watch pathway. We're obviously saving the cardiology bed nights, and there's a significant financial benefit for surgical departments of converting non-elective to elective. Next slide. Over the course of these 96 patients at Barts, we've been able to claim £1.75 million from an elective recovery fund for these patients being elective and not urgent. We've saved almost 800 cardiology bed nights across the system, and we've had no patient-related cancellations in 6 months. So in conclusion, we've shown the proof of concept that using remote monitoring via the Ortus-iHealth app, we've been able to safely convert previously non-elective to elective cardiac surgery patients. We've been able to show high levels of patient and staff satisfaction with our system, and also, in addition, significant benefits for the whole healthcare system. Thank you very much.
Yeah, I can carry on?
Yes, please.
Okay, great. So, sorry for the delay and to rechange in order. So I'm Dan Jones, an interventional cardiologist at Barts, and I'm going to talk to you about a virtual ward we utilise for low-risk NSTEMI, which is the ATLAS or at-home low-risk ACS pathway. So we know in the UK and worldwide that NSTEMI is a common type of acute coronary syndrome. In the UK, it accounts for approximately 100,000 cases per year. This places a significant burden on the healthcare system in terms of significant costs, resources, hospital admissions, and invasive procedures such as angiography. And we know it's important to provide this in a timely manner to avoid adverse outcomes in high-risk patients. But there's considerable variation in the time for admission to angiography for NSTEMI, and many hospitals in the UK are failing to meet these targets. And actually, in 2021-22, only 55% of patients were treated within 72 hours. If we look at last year's MINAT report, this is actually a little lower, about 54% are treated within a timely manner, and that's for all NSTEMI. And this means that patients often wait for a long time in hospital, often 5 to 10 days, because it's difficult to prioritize these high-risk patients, as it's a first-come, first-served system. And this means that there's poor patient experience, low satisfaction, and long hospital stays. And actually, in lower risk patients, the benefit to risk ratio of early invasive angiography is less clear. So actually, there is an opportunity to risk assess and stratify NSTEMIs, trying to provide an early expedited procedures using standardized pathways for the high and very high risk, but actually to offer elective outpatient angiography to lower risk patients, and therefore reduce waiting times overall for high risk and improve experience for these lower risk patients who wait a long time. And that's the advantage of a virtual ward. What we're talking about on this webinar is that these are giving us the opportunity to monitor patients whilst treating them at home that wouldn't have previously been able to do so. And this could facilitate the discharge of low risk NSTEMI patients, allowing them to wait at home for their coronary angiogram whilst being monitored on the digital ward. And this was the premise of the ATLAS, or at-home low-risk ACS pathway. So we designed and implemented this novel virtual ward assisted outpatient angiography pathway for low-risk patients presenting with NSTEMI or NSTEACS. And our goals at the start of this project were to safely discharge patients onto the virtual ward whilst waiting, because this hadn't been done before, to improve and therefore hopefully subsequently reduce waiting times, improve patient satisfaction, be safe, and result in cost savings. And this is just an example. Well, this is the pathway, and at Barts we serve 9 district general hospitals, providing angiography in a hub and spoke model for these acute patients. And low risk patients were identified via set clinical criteria, which I'll show on the next slide, and identified as being suitable for the pathway. And then they were then discharged from one of the referring district general hospitals with an outpatient angiogram date to come back to Barts. They were boarded onto our virtual ward via Ortus pre-discharge, similar to what Marta mentioned on the previous presentation. I need to remember the order of the presentations now, with a confirmed outpatient angiogram date and the necessary medications for antiplatelets, ACS drugs. And it was ensured that the patients had a good understanding and ability to upload their information and answer the questionnaires. And obviously the platform, it contained all the necessary information to explain the procedures to patients in case they had any additional questions. And the patients then completed a daily questionnaire whilst at home, which was then monitored by Barts, and I'll talk about that more in a second. in terms of our criteria, we tried to identify low-risk NSTEMI patients. So these are patients who were admitted. They were then pain-free for 48 hours. They had minimal or limit or no ST change on an ECG, and moderate, so less than 1,000 nanograms per litre in terms of troponin rise, were stable with no evidence of heart failure, ventricular arrhythmia, and were relatively low in terms of grace, and therefore then discharged on optimal medical therapy. So we were trying to identify low-risk patients with clear exclusions for those that you were deemed to be high risk and should come quicker. And if we then look through the dashboard that was created, which we've already seen examples of, the clinician dashboard highlighted the abnormal answers from the daily questionnaires that the patient completed. This was a bespoke questionnaire which was covering chest pain, shortness of breath, syncope, worrying symptoms that an NSTEMI would mean that we'd need to expedite this procedure or their planned procedure. And the color coding in terms of amber or red, amber, green or grey basically helped the ACP who was looking after the ward triaging patients on a daily basis to see who needs to be contacted, maybe have medication changes, maybe be contacted to see if the symptoms were correct, if we need to expedite this procedure, and if so, they were brought straight to the tertiary centre for their angiogram rather than go back to the district general hospital. And the pathway started in October 2022. Since then, we've actually had 1,000 patients through the pathway as of yesterday. So a milestone that was well coincided with Nick's timing of the webinar. But I'm just going to present the information from the first 440 patients because we have sufficient data to do that. And we can see that the average age of a patient on the pathway was just over 60, so 62 years. But actually, there was a good range. Patients as young as 38, and we have quite a young population here at Barts, but all the way up to 86. Were quite happily discharged and utilising the app. Mean grace score was low, consistent with the clinical criteria. And whilst patients were at home waiting for their angiogram, we had to expedite 11 of these first 431 procedures, which is 2.6%, so a small number were relatively then admitted straight here for their cath, not on an elective basis, but 37, so about 8.5% had medication changes. And typically this was the initiation of a GTN spray that had missed off discharge, or an anti-anginal for someone that had exertional chest pain whilst waiting. Anyone with rest pain sat in the 11 expedited angios. And of the 431 patients that had undergone angiography at the time of this data, all were done within 7 days, an average of 4 days. Now, I think the first slide to show is the improved efficiency for angiography. So this box on whisker plot shows the length of stay for patients on Atlas, so prior to them being discharged for their angiogram. And this is 3 days with an interquartile range of 2 to 4 days. So the average Atlas patient was in hospital for 3 days and then was discharged. And if we compare that to patients who were then sat waiting to come across via the conventional pathway, and this included the full spectrum of patients, we can see that the average length of stay is a lot less, being 3 days compared to 7 days, with a significant reduction with the implementation of the pathway. Now, just from those first 400 or so patients, this saved nearly 2,000, so 1,760 bed days. And this varied based on obviously the number of hospitals that we served, but that was on average 150 to 400 days per district general hospital, which for any hospital, this will result in cost savings. And this is around 900k in 10 months, but also the ability to improve flow of patients at that hospital and free up the beds. The pathway also provided improved efficiencies here at the tertiary centre to enable us to schedule patients better through the lab and improve throughput. Typically from an IHT, because of AMI work and elective work, we often find the IHT is the first patient to be cancelled each day, and on average about 1 in 3, 30% of our IHTs are cancelled each day. But patients on the Atlas pathway who would have come via that pathway if they'd been conventionally treated, the cancellation rate was only 0.4%. So it provides predictability for us, a better experience to patients. Did the patient start the pathway? Well, 95% felt safe. 85% would recommend the pathway to their friends and the family. Obviously, allowing for the caveat that this is if you can recommend an AMI pathway, an ACS pathway to your friends or family. But the majority of patients felt comfortable to be discharged and wait at home. And overall, patients on the pathway ranked the pathway at 9 out of 10 on a simple scale, which was significantly better than the patients who came via the conventional pathway during the same time period, who only ranked at 5 out of 10. And actually, some of the best feedback we had from patients were patients who only spent a day or a night at home, but going home and then coming back in your own clothes into the radial lounge is very different than coming across in hospital transport and a gown and being treated in the hospital environment. And there's been quite a lot of positive feedback at just how makes simple things a better experience. In terms of outcomes, are we safe? Well, actually, we did originally think that we'd be selecting a lot of patients without coronary disease, so low risk NSTEMI, meaning normal coronaries. But actually, of the first 430 patients, there's a revascularization rate of just over 55%, both by PCI and also surgery. And as Martin eloquently presented, the majority of patients on the Atlas pathway who needed surgery moved across onto the Watch pathway and underwent their surgery via that pathway. So again, to improve the flow, and you can see the linkage and blurring that gap between cardiology and cardiothoracic that Deb's mentioned earlier. And most importantly, it's safe. Nobody was admitted acutely whilst waiting, and nobody had a MACE event rate or readmission within 30 days of the procedure. And rebadging ACS or acute work into elective has financial benefits for your hospital or your trust, because elective procedures have an increased tariff. The most trusts are on block contract for an IHT, and that meant that their projected cost savings or cost improvement, greater income for the trust, was over £1.5 million over that first 10 months. Now, most importantly, I think the pathway enabled us to free up the waiting list, reduce the queue, and enable us to treat the high-risk patients quicker. And prior to the pathway, we treated 49% of patients within 72 hours, but this actually increased to 70% during that time period because of the patients that then came electively. And just to sort of show the spread, initially the pathway started October 2022 within Barts-Health, the 3 district general hospitals, and expanded to the other sister sites, meaning that it's live at the 9 district generals that serve into Barts, so live at 10 hospitals. And the following presentation and discussions, that the pathway is now live at another tertiary centre at the Royal Free, which was served by Barnet, and with discussions with both the South and North London ODN, we hopefully expect that the pathway will be similarly rolled out across London, as Deb's presented with the surgical waiting list at the start. And not just within London, we've also discussed with centres in Essex and around the country, and hopefully Basildon will actually start in the very near future, meaning that the pathway will then be live at 3 tertiary centres and nearly 20 district general hospitals. So to summarise, I think that this virtual ward assisted at-home low-risk ACS pathway provides healthcare efficiencies, reducing length of stay, providing cost savings, reducing cancellations, and helping with follow-up. It improves outcomes, patients are satisfied and happy, it's safe, and actually we see improved outcomes because we're getting this this higher risk patients across quicker. And this, as both the 2 pathways showcased, is generalisable across any tertiary centre or district general hospital that treat NSTEMIs, because 1 in 5 will be low risk and will be suitable to be discharged, wait at home, and have a far better experience. And I will finish there just with my acknowledgements, and thank you for listening now that you can finally hear me. Thank you.
Thanks, Dan. That was a remarkable recovery and great presentation in the face of overcoming a few technical issues. I'll now ask all our presenters to turn their cameras and microphones on as we move into questions. So let's have a look and see what questions have been raised. The first question we received from Sarah was, to what extent do you use patient monitoring devices, and are they provided by the service, or are patients expected to source themselves?
Shall I take that, Nick?
Please.
Yeah, so as you mentioned, depending on what pathway we have, a lot of our pathways are very much dependent on qualitative data, so symptoms reporting. So we don't provide any devices in those pathways. The one that you've seen today relies on patients having their own internet-connected device. So they can log on via the app, or they can log on via a website, and it really is about just putting in symptoms. We do have other pathways that are more quantitative data, be it like our dissection or heart failure. And again, where patients have their own devices, they can use their own, be it Bluetooth enabled, and where patients don't have devices, depending on the pathway, patients are given devices for a defined period of time. For example, our heart failure virtual wards, we set aside some devices for those patients who simply won't or do not have the means to get their own, and they're given some. So that allows treating everyone as they all need £1,000 kits are not going to scale. So we have that flexibility within the departments to give those who truly need devices then for a short period of time.
Thanks, Debs. Martin, Dan, anything to add to that at all, or does that sit comfortably with you? Okay, we've got a couple of questions that kind of follow it's probably worth leading on from the kind of beginning of the process. One of the questions that's been raised is, what's the key learnings about how to onboard patients into the virtual ward environments, and how much time does it take, and who in the team does it? So, Martin, can I ask you to reflect on how you achieve those things?
Yeah, thanks. So the onboarding is obviously very important, and it's important for the patients to understand the pathway and what we're doing. For the patients that we did in our centre, either myself or one of the nurse practitioners would onboard them. It takes less than a minute when you're sitting with the patient and with their device. Now we've expanded this to other centres where we don't meet the patients. We do it completely remotely. And again, we send the patient the link, they download it and register themselves. And again, it takes less than a minute to do.
Has that been a similar experience for you, Dan? Or?
Yeah, I think so. I mean, obviously the nature of the pathway is slightly different in terms of all our patients go home from a sister hospital that, so we don't meet them prior to them being boarded, as opposed to a lot of the watch where, as Martin had said, would go from within Barts. I think the actual process is really straightforward in terms of being able to board them onto the ward. I think it's the information provided to the patient around the process and the expectations and what they have to do, and it's that bit that we admittedly had some teething work to do. But I think rolling out the platform at sort of 3 hospitals to start with and working through those teething issues meant it was much easier later on in terms of the information provided to the patient, the information provided to the team at the other hospital. We have cheat sheets and patient information sheets, and all those I think are crucial for the understanding, because the actual technical process is pretty easy. It's just the other bits that are really important, which I think I just emphasised Martin's point.
Right. So thank you. And one of the patients in. So one of the questions has asked about the duration for which patients are monitored, and includes the question about post procedure. So is there a view on that?
I'm happy to answer first from the Atlas perspective. I mean, patients are just on the ward until they have their angiogram. Once they've had the revascularization procedure, they're discharged, but we keep them. They're discharged from the virtual ward, but we see them clinically at 3 months via a virtual appointment via the app, but we don't keep them on the ward. Patients who require further surgical management, we deviate to Martin, but we don't keep them on the ward after the angiogram from the Atlas perspective.
Thank you. Let's have a look. What else have we got here? Let me see. Debs, okay. Debs, you talked about the London net, about the rollout across London. One of the questions I've got here is about practices. SOPs, etc. What are the key changes to standard operating practices in running a virtual ward?
Yeah, each SOP, each pathway will have its own differences, the own kind of cadence in which you want information back and the reviewing. So, the Atlas and the Watch pathways, kind of inpatient to elective, they're very much virtual wards by definition, i.e. Remotely monitoring the patients and touching base with them every single day. And it's what we found is really important is to keep that engagement, both from a remote monitoring and a virtual workspace. It's not only touching base with those who are deteriorating, but acknowledging those who are still doing fine as well. So through the platform, not only when patients submit a questionnaire and they're doing fine, en masse, we send them back okay, we've reviewed it, you're doing well. That feedback loop is very, very important. We did have challenges in sticking to those SOPs. That's often, but again, those teething issues were very much resolved. What also has been useful, especially in the Pan London, is everyone following the same SOP, therefore learning best practices off each other. One of the key things that we've tried to do is not reinvent the wheel and learn off each other.
Thanks. I suppose I'm very aware of the time. We promised to be up by the hour. I had another question I think goes very, very current with regard to the challenges faced with resources. One of the questions we had in advance was a question about digital skills training to run and manage a virtual ward. What's your perspective on is this a new discipline? What's required? Is the workforce ready? And what support would be required to really help expand on the use of virtual wards in that sense?
Dan, do you want to take? You've done a lot of work on the AMP workforce, so really there.
Yeah, I think, I'm happy to comment from our perspective. I mean, the Atlas pathways run by the cardiology ACPs. Most of them, they have clinical training, but they haven't had specific virtual ward training prior to the pathway. They had some experience with the Ortus application because of our early discharge AMI, and actually, I think there's obviously a learning curve for everything, but they all took to it quite quickly. I think there are aspects specifically of the virtual ward that once everyone's comfortable logging into an app and using technology. The majority of people these days, I think, and actually it's pretty user friendly. So I think most got to grips with it pretty quickly. To be honest, I think there's a learning curve, but it's actually quite shallow. Admittedly, a lot of our ACPs, are very comfortable with technology being that demographic. So maybe someone that's less used to technology would take a bit longer. But I think that people are relatively few and far between these days. No, but I'd be interested to hear what others say.
Martin, from your perspective.
Yeah, again, we had no specific training in the surgical department on digital tools. It was kind of learning as we go along, and that's why it's important that we use tools that are relatively user-friendly and that we're able to develop as we go along. I think the patients have been important for this. The patients have given us feedback on how they like the app to run, and we make edits based on that. And when the staff see that the patients enjoy it and get used to it, then that develops enthusiasm amongst the staff group as well.
All right. Thank you very much. Now, I'm afraid our time is up. So I'd like to thank our presenters. It's been a terrific session. We covered a lot of ground, and it's been really interesting where we've been able to follow an effective pathway of severity, risk, and be able to look at what the different influences are across the different levels of acuity. What I would ask, if anybody out there wants to put some more questions into the enter any further questions, we'll respond to those online. And just before we close out, I'd just put a quick survey up there to appreciate some feedback on what's been provided today. And if you could fill that out, then I'll leave the webinar up for the next couple of minutes. But please, thank you very much, and we'll formally close it now. And if people would like to leave at their own pace, I'll shut it down in about 5 minutes' time. Thanks, everybody. Apologise for the hiccup, but it happens all the time, even on live TV. So we'll take that one, and we'll make sure it's a little bit better next time. Thanks a lot, everybody, and thanks for joining us, and we'll see you soon. Thanks.